Well, good morning, everyone. I'm Dr. Laura Lacher, and welcome to today's Medical Grand Rounds. Per usual, we'll go ahead and get started with some logistics and then introductions for today's talk. Please be sure to join us next week. We will have the talk Genetics for the Non-Geneticist given by Dr. Marin Josie. We are here at Providence St. Vincent. Grand Rounds is a collaboration between Providence St. Vincent and Providence Portland Medical Centers. We are always here live in the room on Tuesday mornings at 8 a.m. We are sometimes live at Providence Portland, also on Tuesdays at noon. You can earn CME credit by being with us here in the room, by watching on Teams Live, or by watching a recording of the event. If you look at the Grand Rounds invite for each week, it will point you to the link for the recording, and also it will let you know where and when we are meeting. I will monitor the Q&A throughout today's session. So for those of you watching online, please feel free to post any comments or any questions, and then I'll mostly hold those questions to ask as time permits at the end. And now to introduce today's speaker, we are joined by Dr. Tom DeLaury, a native Hoosier who graduated from Indiana State just 1 year after Larry Bird and went on to earn his MD at Indiana University School of Medicine. He came out here to Portland to complete internal medicine residency, followed by hematology oncology fellowship at Oregon Health and Science University. And he is currently a professor of medicine, pathology, and pediatrics in the divisions of hematology oncology and laboratory medicine at OHSU, and head of faculty affairs for the Heme Medical Onc division. Dr. DeLaury's clinical interests are in iron deficiency, general hematology, as well as coagulation, and he has published extensively on these topics. He also has an interest in the hematologic aspects of wilderness medicine and is serving his second term on the board of directors of the Wilderness Medicine Society, and also serves as a board member of the Pacific Northwest Wilderness Medicine. Many of you know Dr. DeLaury is a talented and a generous teacher. We're so delighted to have him back at Providence. Thank you.
Thank you very much. Oh, thank you. You may not be clapping at the end of the talk. Thank you. Great. So my only disclosure is I do author on up-to-date iron deficiency and anemia in pregnancy. So if you have any concerns about that, let me know, or disagree with what I wrote. Anyway, so what we're going to talk about today is just kind of a potpourri of issues that commonly come up that I get curbsided on. We do a lot of e-consults or things I just think about a lot. A quickie is actually a very common both in-person and e-consult I get. And I always like it. Doc, can I stop my blood thinners as my hip is killing me since I can't take Motrin? And this is a big issue because we know nonsteroidal and anti-inflammatory agents and anticoagulation traditionally don't mix. Many, but not all, nonsteroidals have an antiplatelet effect, and they can cause some GI toxicity. On the other hand, many of the patients we anticoagulate are older, have arthritis, pain issues, migraines, and it's nice to take something, besides ketamine for their pain. And so what options are there? And I'm actually a big fan of nonsteroidals. So if my patients, have the need, my rule of thumb is maybe once a week for like a headache or a cramp. But if somebody needs to be chronically on nonsteroidals, that I use a PPI plus DOACs, and then I either go with celecoxib or meloxicam. Those actually drugs do not have antiplatelet effects. So there's still concern about GI toxicity, but at least your platelets will be healthy. Now, as we all know, people's response to these drugs can be erratic, like meloxicam doesn't do a thing for me. And if somebody truly wants their ibuprofen, we just accept the risk. There's going to be a slightly increased risk of bleeding. I mean, that gets grandpa up and moving. I think it's worth it. And there's a lot of studies on this. And this was a nice meta-analysis that was published in one of our journals. And the key to me is just with the risk of bleeding, it does go up a little bit, but not by a huge amount. You raise the risk by 50%. Obviously, GI bleeding is the major concern that doubles with this. And certainly combining Pixaban or Rivaroxaban with a nonsteroidal is safer than combining it with warfarin. So again, I don't make it routine, but if a patient we go through the risk and benefits and want to do it, I tend to do it. So I think that's something that I think helps a lot of people. Now, one thing I do get a million consults about is macrocytosis, and it's most often actually nothing to worry about it, especially if the patient's not anemic. So it's not always a harbinger of doom. So I arbitrarily in my clinic define macrocytosis as over 100. I've always amazed at the different ranges of normals of the MCV. Macrocytosis is not that well standardized, and it's kind of like the red cell being bigger than normal. And as I always teach people, when we see macrocytic anemias, there's two types. There's round, which are membrane defects, and there's oval, and they literally look big oval shape like plump footballs on the blood smear. Those are always more worrisome to me because that's associated with B12, folate deficiency, drugs, or some sort of myelodysplastic syndrome. So again, oval macrocytes, I see in B12 and folate deficiency. Many drugs can do it. We worry about myelodysplasia. But a lot of other things cause macrocytosis. And I think we always have to keep that in mind when we're thinking about macrocytosis. And it's a huge differential. And really, it's the very minority that's due to B12 or folate deficiency. And especially with our food being supplemented, we almost never see folate deficiency anymore. So what else can give you a big MCV? Well, what I tend to worry about if somebody's older or they have their other blood counts down is myelodysplasia. It's a clonal bone marrow disorder with many manifestations, but especially ineffective production of red cells and macrocytosis. And again, tends to be more common either in older people or people who've had chemotherapy. Clues to me are people are anemic. They're anemic, they're gradually getting, anemia is getting worse, and their other blood counts are down. Their platelets are falling, their neutrophils are low. And again, there could be risk factors for this. If I'm really worried about this, you can do bone marrow test. We're working on now just doing genetics on the blood smear, especially in older patients, but that's there. But again, relatively uncommon, but somebody's counts are falling, think about it. Many drugs do this. It's not the classics, cytotoxic chemotherapy. So patients on methotrexate for their arthritis will commonly get macrocytic. Sulfasalazine will do it. Long courses of TMP sulfa will do it. Many of the antivirals and many of the anticonvulsants. So, many of these drugs can do this. And if they're effective, it's a totally harmless effect. Pregnancy actually can raise the MCV. Now, we almost never see this because 80% of women by the third trimester are iron deficient in pregnancy. But if somebody's actually iron replete, there can be a significant macrocytosis in pregnancy. Again, we rarely see this, but can be there, especially if somebody's MCV rises during their pregnancy. Alcohol is the classic, leads to rise in MCV, and it's probably due to two mechanisms. One is abnormal lipid metabolism, which causes a larger red cell membrane, redundancy in the red cell membrane, but also alcohol is a direct poison to folate metabolism. So that's why if you check homocysteines in people who use a lot of alcohol, they'll be sky high because you're poisoning folate metabolism. It can be pretty significant. It can be up to 120. And I would say when I'm consulted on patients with high MCVs and usually normal CBCs, it turns out there is an alcohol history there. So I go looking for that. This is a classic study years ago from the Lancet. Again, normal population, patients with liver disease who can occasionally have macrocytosis, and then people who used over the equivalent of a 6-pack of beer a day or more. Again, you saw pretty significant macrocytosis. So alcohol is always a big cause, and probably even with modest alcohol use, there can be a rise in the MCV. This is another study, again, with the grams of alcohol there, and to remind ourselves that one beer is 14 grams of alcohol, and so that can pile up. But again, even modest consumption can raise the MCV. Liver disease is independent of alcohol. Again, you get abnormal lipid metabolism and liver disease. It's related to severity of liver disease. Again, iron deficiency is very common liver disease, but can mask it. But a high MCV can be seen. And this is a study showing that as the MELD score went up, people tended to have a higher MCV. And some people have actually incorporated this in other tools of severity of liver disease as a tool there. So another cause that often gets overlooked is people with hemolysis or brisk reticulocytosis. A reticulocyte is huge. It's about an MCV of 160. So if you're having a brisk reticulocytosis, let's say responding to bleeding or having a hemolytic anemia, your MCV can be pretty substantial. I've seen it up to 120, 130 in brisk hemolysis. This is a blood smear. I'm a hematologist, so I'm required to show at least one blood smear per talk. And this is a shift cell. It's a brand new red cell. It's still a little bluish from just being released from the bone marrow, but it's huge. It's bigger than its compadres around here. And so that can do it. Now, cold agglutins can cause spurious macrocytosis. And usually the lab picks this up, but sometimes it doesn't. And you'll just get crazy MCVs like up to 180 because the red cells are glomming together and going through the CBC machine, and getting their MCVs is counted as extremely high. So this is the classic blood smear cold agglutinin disease. Again, this won't fit in a CBC machine, but occasionally, sometimes these little guys will get in there and that can raise the MCV. And again, it's usually pretty obvious because it's like nobody has an MCV of 180. Now, classically, we're taught thyroid disease is a cause of macrocytosis. Everybody gets a TSH and that. But actually, at worst, it was a mild macrocytosis. And in the original article describing this, the only people with thyroid disease that had MCVs over 100 also had concurrent B12 deficiency. So although we always check it and stuff, actually thyroid disease only causes a moderate macrocytosis in dark here. And people at higher MCVs actually all had B12 deficiency because there is a relationship between autoimmune hypothyroidism and B12 deficiency. So, we do it to do it, but there's actually probably little use in checking the TSH in macrocytosis. So what other fun things does it? Actually, smoking can do it. Aldehydes and other smoking toxins lead to a higher MCV, rarely over 100, but, just another chance to talk to people that like, look, your smoking's damaging your bone marrow. Why don't you stop it? And again, not a huge difference, but clearly higher MCVs in smoking men than women than in non-smokers. So another bad thing smoking does. So there's actually with COPD a very strong association, especially if the patient's hypoxic. And again, this is because when you're hypoxic, getting erythrocytosis, you have reticulocytosis. So this is going to make your MCV go up. So a nice study here showing that. So monoclonal gammopathies are really common. Maybe 10% of 80-year-olds, maybe 5% of the population. People are now using very high sophisticated tests that the percent may be even higher. And interestingly, 5% of people with monoclonal gammopathies have a macrocytosis. And we're actually unsure why. It's unrelated to the size of the protein, unrelated if they develop myeloma or not, maybe some subtle abnormalities with the machine. It's not a prognostic indicator. I don't solely use it as an excuse to check a certain protein electrophoresis, but it is an interesting association. And we're going to divert here. While we're on the subject of MIS, MGUS is absolutely positively not associated with osteoporosis. I get all these consults for MGUS, like I was working up their osteoporosis. Nice study a few years ago showed that, yes, people with myeloma get bone disease, but it's actually very distinct than osteoporosis, its own specific bone issues. And people with MGUS and osteoporosis, it's the same incidence as the normal population. There's a wonderful study going on in Iceland that's actually a prospective study of people with monoclonal gammopathies, like tens of thousands of people, and they're really disproving a lot of these myths. So something's osteoporotic, you don't know why, don't check an serum protein electrophoresis unless there's another reason. Same goes for anemia. We're always taught, I taught people to do this, but very nice study from the Mayo Clinic database just recently published showed that MGUS really isn't associated with anemia or myeloma. That if people are anemic with it, they're usually severely anemic and have their signs and symptoms. So one thing I go by now is I only check a serum protein electrophoresis if somebody's really anemic, or they have what we cutely call the crab sign, hypercalcemia, sudden onset of renal disease, severe anemia, or new bone symptoms. So I didn't put it on here, but just yesterday I ran across a study actually also saying doing it for neuropathies, unless it's very specific types of neuropathies, is worthless. So do a favor to your local hematologist and only check serum protein electrophoresis when they're crab signs. Okay, copper. Copper deficiency is increasing. I see more copper deficiency than B12 deficiency. There's several classic signs of copper deficiency. It's usually a severe anemia, usually macrocytic. Interestingly, it also has neutropenia. Sometimes that can be severe. The bone marrow looks exactly like myelodysplasia, so it's often part of a myelodysplasia workup to do a copper. And this is common. Think about people with nutritional challenges like TPN. We occasionally see it in bariatric surgery. And interesting cause is zinc toxicity. And our neurologist a few years ago wrote up a large case series of people with neurologic defects due to copper deficiency who were chewing their denture cream. I guess denture cream is full of zinc, and people would kind of chew on it and swallow it, thinking, well, if I can put it in my mouth, I can swallow it, and would get zinc toxicity. I love the fact that this is another cause of zinc toxicity. People who love to eat pennies will get zinc toxic. And that's because pennies, which rest in peace now, they're going to stop making them, are a very thin shell of copper and are 99% zinc. So I always find the irony that eating copper pennies actually gives you copper deficiency because you shoot up your zinc, boom, and you drop your copper levels. And I've seen people with absolutely no reason. They just are severely copper deficient. What are the clues? It's actually a very specific picture. It's an ataxic and sensory loss, so usually difficult in walking just because people can't remember where their feet are. They have trouble their brain remembering to move it around. And the heme picture is a very unique one. You see neutropenia, anemia, macrocytic, often transfusion dependent. But interestingly, your platelet count is almost always normal. Every case I've seen and many of the cases in the literature had a normal platelet count. And that is really unusual. Usually your platelets are like the weakest link in your marrow. And if your marrow starts to go, your platelets go first. So it's very interesting. If I see somebody neutropenic, anemic, but normal platelets, I think of copper. Diagnosis is pretty simple. You get a copper level. You get a ceruloplasmin will be low, but copper level's low. Therapy is simply giving copper. And I would have to say that usually in copper deficiency that causes disease, they're very low. I think the upper range of normal 60, it's levels like 5, 10, 20. A lot of people have mild low levels of copper. It's due to being heterozygous for Wilson's disease, and that doesn't mean anything. But give copper, you can give it orally, and people will be better. So it's not esoteric. Like I said, for whatever reason, we don't see folate deficiency anymore. B12 tends to be rare. And I think for a variety of reasons, we're seeing more copper deficiency. So what do I do when I get asked about a patient with macrocytosis? First question I ask myself is, are they anemic? Because if they're not anemic, it's really unusual for anything bad to be going on. And there's this entity called benign macrocytosis, which means we just don't understand why yet a lot of people have this. And they have normal blood counts, no underlying hematological disorder. The vast majority of patients, especially if they're younger, the natural history is very benign. Interestingly, it actually can be familial. So it's probably some subtle defect in making the red cell membrane. So if they're not anemic, I evaluate the nutrients, MMA, homocysteine, copper. I'm sorry, I'm traditional. I still check a TSH every tick count. I would have to say I have yet to find anything abnormal in years of doing this, and maybe I should stop doing it. But I just do this just to be sure. If they are anemic, then to me, I get a little bit more worried. If they're older, if there's other things going on, I'll check an SPEP and light chain. If it's very worrisome, I'll do a bone marrow to look for myelodysplasia. And again, especially if they're pretty anemic. So again, anemia to me is the big tipping point in when I evaluate macrocytosis. So about aspirin, I hear this every day still in my clinic. Well, yeah, doc, I got AFib, I'm on aspirin because it's safer. Or, like, well, can I just treat my DVT with aspirin? It's safer. What is it? So I'm going to give you the answer in a second, but aspirin's been around forever. That's why people love it. It's been around forever. It's dirt cheap. You can go to Costco and buy a 55-gallon drum barrel for $1 saran wrap to another barrel of it. We just love it. And I also like the fact that aspirin came on the market right at the same time as heroin, the sedative for coughs. And everybody thinks these are fake, but these are actually real ads. Bayer made and sold both of them, and both are still big sellers. The other thing I noticed in reading this was the heme drug, somatose. And I had to look that up. It's a crazy name, because most people are tired with anemia. Why would you give them something called somatose? But apparently it was very valuable, and this guy really liked it. So what's the bottom line of aspirin versus warfarin? Actually, no difference in intracranial hemorrhage with the use of these two agents. And that's a very important point, because that is almost always the fatal toxicity of anticoagulation is bleeding in your head. There's no difference. There was a great study called the Birmingham anticoagulation trial in older people. I don't know how the A was older, but these randomized people over the age of 75. And back in the day, this was really controversial, anticoagulating old people. How could you do that? And they randomized people to warfarin versus aspirin, follow them up for 2 years. So the average age was 80. And what they found is absolutely no difference in bleeding, no difference in extracranial hemorrhage, no difference in major hemorrhages, no difference in intracranial hemorrhage. Again, a selected population of very old people. Absolutely no difference. The only difference in this trial was warfarin was phenomenally superior in preventing strokes. And again, if you look at a large database from this Scandinavian country where they really keep good track of this, when you compare aspirin and warfarin for risk of bleeding, no difference seen with this combination. And what do we know? Well, we know warfarin, which most of the older trials were based on for AFib, was vastly superior. If you had a history of stroke, you had an absolute risk reduction, no history of stroke, low risk of stroke. So warfarin, has always been shown to be superior, and really with a slight risk. And now that we got the DOACs, it's even better. And even in the day in the aspirin trials, warfarin did not reduce the risk of disabling stroke. Aspirin did not reduce the risk of disabling stroke. Warfarin clearly even reduced the risk of fatal stroke. And I'm quoting the warfarin data because these are the only versus aspirin versus placebo trial, because it wouldn't be ethical to do these days. And DOACs even have a better number with this. And mobile AHH guidelines have said this, that there was only one study that's ever shown the benefit of aspirin alone in preventing stroke. It's a small study. It actually didn't work in older people. And it doesn't work to prevent stroke in over 75. Aspirin doesn't work to prevent stroke. Never been really studied at low risk of AFib. And mobile guidelines for the past 10 years have not recommended it. And it's even worse when you look at the DOACs. In a trial of people felt to be too high risk to be on warfarin, You had aspirin versus apixaban. Apixaban was much, much more effective, identical risk of bleeding, identical risk of intracranial hemorrhage. So when I see somebody, they're like, oh, can we put on aspirin? I think they're too high risk of bleeding with apixaban. I'm like, there's too high risk of bleeding with aspirin then, choose your poison. And another really interesting trial was using DVT. There was a brief flurry of interest of aspirin for long-term prevention of DVT. This is a trial that looked at rivaroxaban. This is 6 months after having a DVT or PE. They looked at 20 milligrams a day versus 10 milligrams a day versus 100 milligrams of aspirin daily. Ineffective at preventing recurrent DVT compared to either dose of rivaroxaban, identical risk of major bleeding, and identical to maybe slightly higher risk of bleeding with a higher dose of rivaroxaban. But clearly with low dose therapy, absolutely no difference. So absolutely no difference in bleeding. Rivaroxaban was just better at preventing blood clots. This is a major meta-analysis of all the trials to date that was published in the Annals a few years ago. Again, no difference of aspirin and the direct oral anticoagulants in major bleeding. No difference in intracranial hemorrhage. So what's the bottom line on aspirin? Except for people with atherosclerosis, really it's an inferior drug. It's limited to no effectiveness. It's not effective in older patients for prevention of stroke and AFib. It's not effective in preventing disabling stroke and atrial fibrillation. It's less effective for primary and secondary prevention of DVTs. It's by far not the safer choice, and in many situations not recommended. So again, we need to put aspirin to rest for a variety of its indications. So again, it's a great drug if you're having a heart attack. It's a great drug if you have atherosclerosis and complications of it, but it's not used for AFib. It's not useful for DVT. So sadly, we got to put aspirin to rest for that. So what's another drug we need to put to rest? Standard heparin for treatment of venous thrombotic disease is actually a barbaric relic of an ancient era. Now, obviously, I'm being a little hyperbole there just because I like it, but I think we really got to get out of this mindset that if somebody has a DVT or PE, we automatically reach for the heparin drip. We showed in the 1990s that low molecular weight heparin had better outcomes in people with venous thromboembolic disease. You get therapeutic levels a lot faster, a clear, not abolishment, but clear reduction in heparin-induced thrombocytopenia, and it's A-okay to use low molecular weight heparin in people who may get procedures. And it just drives me nuts, like, oh, they're really sick of the PE. We got the heparin drip going. And like, yeah, and in 3 weeks, you'll get the PTT therapeutic. So this is one study. Again, it's older because we stopped studying this after we proved the point, showing that low molecular weight heparin was better in preventing recurrent DVTs early, late, and was actually associated with less bleeding. Now, it's interesting. Recurrent DVTs, days 16 to 90, people are not on low molecular weight heparin. They're not on heparin. At this age, they're on warfarin. And study after study till this day shows that, interestingly, the faster and better your therapeutic in the beginning of your therapy, the better you'll be even months later. There's something about getting early control of venous thromboembolic disease. And I think that's why the dog's been so great in a lot of this. This also reminds us that even as an inpatient in the hospital with a big PE, you're better off getting low molecular weight heparin. Now, this is a study that was fascinating, published a few years ago in the emergency medicine literature. This asked the simple question, in 48 hours, how many people were therapeutic getting standard heparin drips? The answer is a minority of patients, 42%. A little bit were over anticoagulated. A lot of people, consistently over 40 to 50% of people for their first 2 days of being treated were not therapeutic, which has been associated with inferior outcomes because standard heparin is very difficult to dose. If I give somebody low molecular weight heparin, they're almost always therapeutic. If I give somebody standard heparin, let's get the Ouija board time, because their inflammation, their nutrition, there are other coagulation factors, things we don't know, their weight, it all adds into it. So the problem is this, it always surprises me. Somebody will come with a big PE and they're on a heparin drip, and I go, why? And they're like, they got a big PE. I'm like, that's the patient you want anticoagulated rapidly and standardly. So think about it. And a lot, I think, of heparin, use of heparin in venous thromboembolic disease has been driven by the idea of doing interventions. The big thing now is, they've had a big PE. Maybe we'll do catheter-related, thrombolytics, or we'll do this. We got to do a procedure. Again, studies have shown it's absolutely safe. And in fact, the PE consortium, the PERC consortium, the rapid response team, recommends low molecular weight heparin. These are the people who think everybody needs a procedure, and they recommend low molecular weight heparin because it's better. So things to remember about low molecular weight heparin. You can use it before procedures. You can use it. It's actually safe for renal disease. And there's no issues with pregnancy around the time of delivery. So again, standard heparin is great if you're getting cardiac bypass. Our cardiologists love it for, their procedures, and I don't want to get in the way of that. But for venous disease, it should be rarely, if ever, used, because we've shown for 20 years now, low molecular weight heparin works better, and we can do procedures and anything we want with it. Okay. So going to something even more controversial, how do we tell people to take iron? TID, every day, every other day, when there's a full moon, what do we do? Well, why is this controversy? I mean, this is something we learned in medical school. Why do people even care? Well, it turns out there's some tricks we've realized about iron and giving iron to people that can really help us in our practice. So one thing is heme iron is 10 times better absorbed than non-heme iron. So it turns out there's a specific receptor for heme iron. You absorb 30% of it. You absorb 10% of most of non-heme iron. So that's a trick I use in practice. And remember, fish and chicken have heme iron. Meat protein itself also improves iron absorption. This we don't understand why. It's independent of heme iron. This is a great study, it's been replicated, where people gave people iron pills, and with milk, cheese, or egg protein, really no big difference in absorption. But if you gave beef, pork, lamb, fish, and chicken, it doubled the absorption of iron pills. So if my patients are willing to eat, any type of meat, fish or chicken, which a lot of people prefer, they should take it with their iron. It will double the absorption. And as I've often joked, my goal is to invent an iron pill wrapped in bacon. I'm going to call it iron in a blanket. It's like, Mike, pick it out of this hellhole. So anyway, but I patented that. But that's something I'm pretty big on doing. We all know calcium fiber can block iron absorption, but this to me is the virtue of vitamin C. Now, vitamin C is surprisingly also controversial. That's the fun thing about classical hematology. We just argue about the same questions for years. But probably if you take iron and vitamin C or orange juice on empty stomach, it does improve your absorption of iron a little bit. But to me, the big virtue is if you're taking my advice and eating a iron pill to cheeseburger, the vitamin C you take will neutralize the effect of cheese on iron absorption, and you can absorb iron. So fiber, calcium, you take 500 units of vitamin C, that's neutralized, you can absorb the iron. The two big killers of iron absorption that looks like we cannot overcome is tea and coffee. Tea decreases iron absorption 75 to 80%. It's not the caffeine, it's probably the tannins and stuff that give tea its rich, robust, I'm a big tea fan, flavor. And so not an hour before, not an hour after when you take your iron. Coffee probably does the same thing. What's amazing is there's very little research on it. I don't know if it's been the Starbucks have like kiboshed this or what, but the only study is those 5 ounces of coffee. And I don't know if they even have these anymore, but when I went to college, you used to have coffee vending machines that give you like a little cup of the world's worst coffee. And I've always wondered if they've done that in this research. I have no idea what a grande venti, you can tell I don't drink coffee, does to iron absorption. So that's why a lot of my patients will take their iron with an evening meal, is to avoid the tea and coffee issue. And I would also have to point out that a few years ago, one of the medical school classes was so upset by this, they started throwing things at me. The gut can only absorb a limited amount of iron. That's really been a major discovery, is you can't absorb more iron just by taking more iron pills. And it really maxes out at 10 milligrams. So a guy named Crosby years ago did a lot of interesting studies. And one of them is he just gave people iron pills every day. First day he gave iron, the iron shot up. Second day, a blended response, and it stayed that way. And he called this the mucosal iron block, because he said, gee, this is interesting. People, you can't really make people absorb more iron by giving them more iron pills. And this is actually turns out the body's regulatory response. If I took a Fred Flintstone vitamin this morning with iron, my serum iron would go up. But then a chemical called hepcidin, which blocks iron absorption, also goes up. And this actually stays elevated for 24 to 48 hours. So if I take an iron pill at noon, if I take one at 6, it's not going to be absorbed because my levels of hepcidin are up, blocking the iron absorption. And this was shown by this really, I think, underappreciated trial from a few years ago. Older people were randomized to 15 milligrams of elemental iron a day versus 50 TID. Absolutely no difference in the rise of ferritin over 3 months, with a 10-fold difference in iron dose. Ferritin rise was the same. The only difference was that people with higher doses of iron had much more GI complaints. So a little iron goes a long way. Now, this led to the whole everyday versus every other day controversy. And it got started by this article that people got 14 iron pills. And they either got the 14 iron pills every day or 14 iron pills every other day. And if you have 14 iron pills and take them every other day, you actually had better absorption of iron. And that's because that after 48 hours, hepcidin wears off and you get better iron absorption. But unless you belong to a really strict HMO, you're not just going to get 14 days of iron. If you actually take 28 days of iron, you still get much more iron absorbed. So one camp was we should take iron every day. The other camp was it should be every other day. It's better absorbed. It's better tolerated. And this actually ended up being a big raging argument. Yes, we really have boring arguments in hematology. Anyway, it's like my old joke that we still argue about compression stockings, and I chose a career where our biggest controversy is wearing socks. So anyway, so the bottom line study was finally published on this. And so it gave people 90 days of iron, either every day or every other day. What did this show? With everyday iron at 90 days, your ferritin was significantly higher. You know, you got there with every other day iron, but it took longer. And the ferritin drops off because a lot of these people stopped their iron, they had GI bleeding or other issues. So if you want the iron to go up fast, you give everyday iron. But there is a price. GI toxicity was significantly higher with everyday iron. And it was actually pretty minimal with every other day iron. So it's a trade-off. So what's the bottom line? Everyday iron, you get faster improvement. Every other day iron is better tolerated. So I think it's dealer's choice. Personally, I tend to start with everyday iron because I want people's irons up fast. Colleagues of mine will do every other day iron because they want it be better tolerated. And to be honest, I think the best way to give every other day iron, because nobody can remember it, is just to give it Monday, Wednesdays, and Fridays. So dealer's choice. Somebody's had issues with iron before, they have a lot of stomach issues, do it every other day. You know, they're pretty anemic. You want to get going fast. Every day, then, you know, cut back if they're having toxicity. So I think that's kind of now where this argument's ending up. Now, people always ask me, they go, Tom, you're a hematologist. What is the best iron pill? And the best iron pill is one people can tolerate. And everybody finds that very anticlimactic. We and others have actually looked at this. And really, if you look at the data, there's no big difference between any brand or any formulation of iron. In general, people don't tolerate iron in empty stomachs. That's why I like giving it with food, just because people I think, have better adherence to it. And if it's a meaty meal, they'll get better absorption. So what do? I use the cheapest iron pill, which is still, when I go to the store, ferrous sulfate. I give it once a day with meals. Again, that's a little different than people recommend, but I want it tolerated and absorption. So I give it with usually an evening meal, 500 of vitamin C, no tea or coffee an hour before or an hour after. They get GI upset, giving it every other day can help, or giving some of the proprietary brands or like 18 milligrams of elemental iron can help. But that's kind of how I get people on iron and get them repleted. So I think it improves tolerability and is pretty cost effective. So what if this doesn't work? Somebody has inflammatory bowel disease and they have a lot of issues. They get stomach upset. They need IV iron, but everybody worries about the allergies. So free iron is very toxic. If I were to grind up a nugget, a thing of iron and shoot it into you, you would be very sick. And so IV iron preparations are actually coated with carbohydrate. This allows them not to be toxic, and this allows them to be uptaken by the macrophage and storage depot. And that's how we increase iron stores. We give people these carbohydrate iron complexes, the macrophage eats it up, and then starts to divot it out and give it out to the developing bone marrow. And so I don't know if it really looks like this. I like this because I also like astronomy, and this looks like a planet. But basically, you usually have an iron core and some sort of carbohydrate shells. So all the IV irons on the market are only different because they have different carbohydrate shells. Infed is low molecular dextran, injectifers, carboxymaltose. These carbohydrates will have different properties and stuff. So ferrolicet, vinifer are just compounds of iron and glucose or sucrose. It actually tends to be less bound, and others may have other properties. And so simply you get the, let's say here, ferric carboxymaltose, your macrophage takes it up, it puts some into storage, and then it ships it out to transfer into developing red cells. So we have multiple preparations, all with unique sugar compounds. And that's really the difference with all the IV irons, and accounts for their pharmacology and everything else. Everything's just a little bit different. There's actually 6 on the market right now. How do you choose? Well, the first thing is, for most of my patients, I don't use the iron salts, vinifer or ferrolicet. Why is that? You need multiple doses. The problem is these compounds have high levels of labile iron, and if you give a huge dose, people have a lot higher incidence of reactions. So there was a study of trying to give 500 milligrams a day, people reacted. Now it's interesting, some colleagues of mine, I believe at the Mayo Clinic, have demonstrated you can get 500 milligrams of vinifer safely, but you got to do it over 6 hours. And that seems to defeat the purpose. So again, for dialysis, EPO, maybe a little top off, they're great. Unless I'm forced to by insurance, I don't do this in my practice. Now, what about reactions? That's what we all worried about. Like, oh, my Uncle Joe got iron, it killed him dead. These are complement-mediated pseudoallergies. A, that's a great phrase that rolls off the tongue. But B, what it means is the drug non-specifically activates complements, these carbohydrates that do that. So it's like rituximab and many biologic. It's an infusion reaction. True anaphylaxis is very rare. A friend of mine, Michael Auerbach, who I sometimes kindly call the king of IV iron, has given probably 100,000 doses of IV iron. He checks a tryptase on every reaction to see if it's allergic, and he has yet to have a positive tryptase there. So it's really, true allergic reactions are really rare. It's just non-specific reactions. So what happens is, like liposomes, like that example, but rituximab and other things, for reasons we don't understand, the carbohydrates can activate complement. You get complement activated, And, you start getting allergic symptoms. Your throat scratches, you're wheezy, you get a rash, but it's not an allergy and it will just go away. So what is the implications of that? And they're pretty interesting. One is, some IV irons make you give a test dose. It's not an allergy. It doesn't mean anything. We stopped doing test doses years ago. Pre-meds don't help. There's actually good data that actually Benadryl makes things worse. And interestingly, there's so many complications of Benadryl actually now working to actually take it off all the order sets because it actually makes reactions worse. Like, oh, now my mouth is dry and I'm tachycardic. And we treat these as an infusion reaction. So yes, people will react. We're like, okay, we'll stop the infusion. We'll wait a little bit. We'll restart it. You'll just be fine. And there's no safer iron. The risk is the same with all preparations as far as reactions are concerned. So you can look this up later. I'm not going to go through this. But again, if it's a mild reaction, we stop, we watch, and we just restart the infusion a little bit slower. If it's a little bit bigger one, it happens again when we restart, we'll just give a different iron on a different day. Severe reactions are very rare. Now, how do I know this? We looked at our data. Over 6 years, we gave almost 36,000 infusions of IV iron in our clinics at OHSU. We like IV iron. And what we saw is statistically, there's no difference in reactions with any preparations. And severe reactions that people really got sick, had to be sent to the ER, was about 1 in 15,000. It was even unclear if those were true allergies or other issues. So IV iron is very safe. So pre-meds were no value, or this was confounded. Test dose was no value. The only thing is people had a history, one of those med lists on, the allergy list on Epic that just kind of goes on and on. That was a predictor because people react. That just shows a patient reacts to a lot of things. Now, what about infections? That's always a big thing. Well, Tom, my patient's pneumonia, my patient's osteomyelitis. We give them iron to make the infection worse. It doesn't. So we have a good randomized trial showing that there's no increased risk of long-term infection. And we have newer late-breaking data on even acute infection. So the pivotal trial was a key trial in renal disease, showed that just giving tons of iron was good. But the other thing was that there was no increased risk of any infection, no increase or no change in risk for hospital infection, no change in death from infection. And curiously, it actually was protective. So that was good. To be presented at our HEME meetings, so DDD late breaking news, which are this week, somebody did a prospective match cohort study of 86,000 patients with infection and found them a match. And they documented people getting IV iron due to acute infection. These were people getting antibiotics. Now, maybe kind of amazingly, and that's maybe a curse of these type of studies is, if anything, IV iron actually improved mortality. So they looked at 15,000 people of MRSA sepsis getting antibiotics, and 14-day mortality was half in the IV iron group and a third lower at 90 days. Similar things were seen with pneumonia or mortality. Now, again, these could be confounded, there could be issues, but clearly there was no signal that IV iron was harmful. There's always been a literature kicking around that, iron's important for immune response. Maybe at least we'll have some true studies on this. But if somebody's sick, give them IV iron if they're iron deficient. So what do? I like low liquid iron dextran. It's the cheapest. You can give it in an hour, very cost effective. I test a ferritin a month later. My goal is to get over 50, over 100 if they're older or symptomatic. I repeat it every 3 to 4 months. And again, for Moxetol, there's a single dose that insurance never pays for, even though it's more cost effective. There's Monifer, which is very expensive. Why do I have Injectafer, iron carboxymaltose grade? It's actually the most commonly used IV iron in the United States because it makes people worse. The carboxymaltose component causes hypophosphatemia. Half of patients will have low phosphorus, 10% have very low phosphorus. It's actually clearly associated with harm and fatigue, and why we're trying to reject this as any first-line therapy. This is a study of giving people inflammatory bowel disease, 2 types of IV iron. The hemoglobin response was the same. It didn't matter about phosphate, but the people who got iron carboxymaltose injectafer did not respond as well and had remaining fatigue, and this fatigue was related to the low phosphate. So given it doesn't make people feel better, low phosphorus can cause other harms, we're really getting away from injectafer. So what's the bottom line? Okay to use nonsteroidals if needed, if your patient's on anticoagulants. Macrocytosis is common. There's a lot of interesting causes. Aspirin only for the complications of atherosclerosis. Iron pill once a day at most. Meaty meal, people want to do that. Give it vitamin C. And if needed, IV iron is good. I'll stop there, and I thank you very much for inviting me and paying attention to my talk, and I'll be glad to field any questions.
Fantastic. Thanks so much, Dr. DeLaury. We'll see if we have questions in the room. While people ponder, I'll get us started with one. Can you speak a bit more to the use of low molecular weight heparin, both prophylactic and therapeutic for VTE in the setting of renal dysfunction?
Yes, so that's a great question. So this again was looked at in the 90s. Reminds me of the old song, Think of the 90s. Anyway, and so it turns out that the only issue with low molecular weight heparin renal disease is the half-life's longer. And so for therapeutic use, we give it once a day instead of twice a day. And there's actually several nice studies showing that if you compare that with unfractionated heparin, the risk of bleeding is the same or actually lower. The issue is if you have severe renal disease, like renal failure and on dialysis, your rate of bleeding is high. It's 30% with any anticoagulant. But there's no big difference, or even better with heparin. It's much easier to monitor and to give. And so it's why we tend to go with that. So certainly for therapy, we do adjust the dose, but once a day, get the patient out of the hospital quicker. For prophylaxis, for short-term use, we still will use 40. Sometimes in people with severe renal disease, there are 30 syringes, and sometimes we'll cut it down to and make it 20. So you can use with proper dose adjustments.
Thank you. And would you say it's wrong to use traditional heparin because of higher risk of HIT? Just, fielding the questions we'll get.
Yeah. So it turns out with the use of standard heparin in a therapeutic course, the risk of hepatoscytopenia is still about 5%. And with low molecular weight heparin, it's 1% or less. So we actually stopped using, especially in our medicine wards, standard heparin after a couple of bad cases of HIT with people getting prophylactic dose. The other thing is it's actually cheaper to use low molecular weight heparin. They're price compatible now to standard heparin. Sometimes it's actually been cheaper. And if you're giving a dose once a day versus having a nurse go and see a patient 2 to 3 times a day, it's actually much more effective. And so I think that's the other myth is low molecular weight heparin is no longer expensive.
Fantastic. Here, busting myths. Thank you. Questions in the room?
Thank you for a great talk. Where do you stand on DOACs versus low molecular weight heparin for DVTs in cancer patients?
That is great. I stand firmly on the side of DOACs. So what's very interesting is there was a series of studies started comparing low molecular weight heparin, which we know is better than warfarin in cancer patients, versus DOACs. And the expectation was they'd probably just be as effective, but with less bleeding. The interesting thing is what we've seen is almost the exact opposite. That interestingly, they've been better than low molecular weight heparin in most settings. Little higher risk, especially GI bleeding, especially with some of the drugs, not as much apixaban. So in general, because A, patients prefer it, and B, it does seem to work better, I almost always start with apixaban for my GI cancer patients and for all my cancer patients. And again, apixaban, because it does not seem to be as associated with GI bleeding. And so, people break through, then weirdly, we go to low molecular weight heparin than higher doses. But off the bat, I tend to go with DOACs.
Great. I'll take another question.
Can you speak to the use of aspirin for VTE prophylaxis in post-surgical orthopedic patients?
I used to joke if I was ever found unconscious that somebody would just have to whisper, instead of going, Tom, Tom, are you awake? Just whisper aspirin for prophylaxis and I'd wake up. I would have to say, based on extremely personal experience of getting a hip replacement a couple of years ago, I challenged my orthopedic surgeon on that, who was warned and pulled out of his pocket the DVT statistics for the hospital I went to for the past 5 years. You know, I still think that that low molecular weight heparin or DOACs do work better than aspirin. There is a large randomized trial going on trying to finally answer that question. I think the biggest change in orthopedic surgery is when I got my hip replacement, I was in the hospital 6 hours. I mean, I was walking the second I stopped screaming in pain. And, I stopped and got a Diet Coke on the way home. And so I think in young patients, I still think of myself as young, who mobilize, who are walking, that it's probably still dealer's choice. If my orthopedic preferred aspirin and he was going to use tranexamic acid with me and I went, fine, I'll be up and moving. And so I think that it's a trade-off. I do think in people who clearly had a history of DVT, who are going to be in the hospital, are going to be more complex, my gut feeling is still a DOAC or low molecular weight heparin is better. But I think with these speedy surgeries, getting people in and out, especially with hips, getting people up and walking, I did stairs the first hour after surgery, probably the overall risk is pretty low at DVT and anything goes.
Yeah, thank you.
Speak to using low-dose DOACs, because we do seem for secondary prophylaxis for DVT, so after people finish their completed their treatment course, whether you can, because it seems like and you showed some data, at least in cancer patients, that were using the lower dose. Is that going to be a future where eventually we're going to reduce the risk of bleeding by doing low dose?
So, it's like hyperbole day today. Yes, the future has been illuminated. So it turns out there were a few years ago, 2 trials that looked at, standard 5 BID, 20 once a day versus lower dose, 2.5 BID, blah, blah, blah. And the lower dose was just effective. It is a hint, but not that clear the risk of bleeding was less. There was a large study recently published from France where, again, they looked at that question and they powered enough to look at bleeding. And people on lower doses definitely had less bleeding. And so my practice now is that if somebody's 6 months out from a DVT or PE, and there's just not some weird factor like that, antiphospholipid or something, I will offer them low dose therapy. And what I say is it reduces the risk of bleeding slightly. And what's been interesting is there's 2 responses. Most people go, that's great. I like being on less drug, the less risk of bleeding. What's interesting is I have a population of patients like, I really hated having a PE. I'm going to stick with the regular dose. So it's very interesting. So I think the evidence, the benefit of bleeding is not enough that I'm going to strong arm patients, but I think I offer that to patients. And it's usually what I call just the average patient. If somebody's really obese, like over 150 kilos, I don't do it. Somebody has antiphospholipid or it's a weird clot like Budd-Chiari. But if it's, I hate using this term, but like, the average DVT or PE patient, I think that's a really great option.
Great, thanks. We'll sneak in one more question from online here. What is your protocol for IV iron in iron deficiency anemia for surgery patients? Do you give IV iron at a higher ferritin threshold, for example, 1 to 300?
That's great. So we tend to base on the surgery, and we do have a pre-op anemia clinic. And we tend to use a goal of 100 because usually they're going to be older patients, surgeries with expected blood loss, and again, especially like in joint replacements, we want to get people up and moving. And so we tend to be a little bit higher in that situation, and we'll do it under 100.
Great. I believe we are right at 9 o'clock, so we will wrap things up. Thank you so much, Dr. Lowry.